Welcome to Best of ESMO 2023 Breast Cancer China session. But, before you start, please take 10 seconds to learn how you can be more than just a spectator at P2P. Right now, tens of thousands of healthcare professionals are actually watching this video. You may take this opportunity to post your own cases, best practices, and research data in the comment box underneath the video. So, don't miss out on this chance to make your work known to global peers. Professor Giuseppe Curigliano from the University of Milano will be speaking on innovative HR-positive disease treatment approaches, current HER2 positive outcomes and therapeutic strategies, as well as novel triple-negative disease analyses.
Ladies and gentlemen, good morning. It's really my pleasure to be here with you. And we are going, of course, to present in this Best of ESMO Breast Cancer 2023 the ESMO Breast 2023 key takeaways. I am Giuseppe Curigliano. I am the chair of the Clinical Practice Guidelines Committee at ESMO, and I will try to provide an overview of all the new data that have been presented during ESMO 2023. Those are my disclosures. So let's start, of course, to provide an outline of my presentation. Data have been presented on HR-positive disease, specifically the long-term patient-reported outcomes for MonarchE. Then the prognostic and predictive effect of body mass index in postmenopausal HR-positive breast cancer patients. For HER2-positive disease, we had the long-term outcomes of neoadjuvant T-DM1 plus pertuzumab and docetaxel carboplatin plus pertuzumab trastuzumab in HER2-positive disease. And then finally, the randomized phase 2 trial of neoadjuvant atezolizumab in combination with dual HER2 blockade. In terms of triple-negative disease, data of the phase 3 in patient 031 trial evaluating neoadjuvant atezolizumab in combination with chemotherapy in patients with early triple-negative breast cancer. Of course, what I will do, I will try to do a summary of all the most important data. And let's start with the MonarchE. The MonarchE was a prospective randomized trial including patients with HR-positive HER2-negative disease and non-positive high-risk pre- and postmenopausal women. We have two cohorts of patients, the cohort 1 with high risk based on clinical pathological features, more than 4 nodes, 1 to 3 nodes, and at least one of the below grade 3 or tumor sites more than 5 centimeters. And in the cohort 2, we have high risk based on Ki67, 1 to 3 axillary nodes, Ki67 more than 20%, and then right wing 2 and tumor size less than 5 centimeters. Patients have been randomized to abemaciclib plus endocrine therapy or endocrine therapy alone for a total of 2 years. The primary endpoint was invasive disease-free survival. Secondary endpoint was invasive disease-free survival in Ki67 population, distant relapse-free survival, overall survival, safety, PK, and patient-reported outcome. In the cohort 1 were included 91% of the patients. In the cohort 2, only 9%. With a longer follow-up, it still confirmed the benefit in terms of reduction of invasive disease-free survival in the abemaciclib plus endocrine therapy arm, with 499 events in endocrine therapy alone, versus 336 events in abemaciclib plus endocrine therapy, with a hazard ratio of 0.6 and a nominal P that was statistically significant. You can see here a 33.6% reduction in the risk of developing an invasive disease-free survival event, with an increase in absolute benefit of 4 years comparing to 2 or 3 years. Looking at the subgroup analysis, you will see here that in all the subgroups, independently of nodal involvement, of grade, of stage in terms of T stage, of prior chemotherapy, of menopausal status, age, there is absolutely a benefit from abemaciclib. There is no subgroup analysis by germinal BRCA mutation. We know that in a few weeks from now, the data of NATALEE are going to be presented. And the data of NATALEE meets the primary endpoint. And so it seems that 3 years of abemaciclib 3 years of ribociclib at the dose of 400 milligrams seems to demonstrate a clinically meaningful benefit in a broad population, including also intermediate risk. What's about the other CDK4/6 inhibitors? We know perfectly that both PALLAS and Penelope B finally failed to demonstrate, of course, a benefit in their studies. During ESMO Breast 2023, the data of long-term patient-reported outcomes have been presented. And here we have exactly the quality of life. The patient-reported instrument completion rates were more than 90% while on study, and less than 80% during the post-treatment period. The scores were similar between abemaciclib plus endocrine therapy versus endocrine therapy alone, according to FACT-B subscales, FACT-ES scales, FACIT fatigue, which indicated that overall the quality of life was preserved. Most patients reported experienced diarrhea, not at all, or a little bit in the abemaciclib arm. Here we have in gray, not at all. Here we have, of course, the rate on study treatment and post-treatment period. 1 a little bit, 2 somewhat in yellow, 3 quite a bit in blue, 4 very much in pink. So when present, diarrhea was most often reported as a little bit or somewhat and diminished over time. Rates reverted to baseline values after completion of abemaciclib demonstrated, of course, reversibility. Major patient-reported outcome findings support a tolerable and reversible toxicity profile for abemaciclib plus endocrine therapy in early breast cancer, while there were differences in the individual PRO item for diarrhea. When diarrhea was present, it most occurred early during treatment. Symptoms were reversible upon completion of abemaciclib, and all these data support the use of Adjuvant abemaciclib in patients with HR-positive, HER2-negative, high-risk early breast cancer. With 50% of patients experiencing diarrhea over a 2 years period, of course, we need still improvement. Another important trial was the final analysis of the placebo-controlled randomized phase 3 inpatient 031 trial, evaluating neoadjuvant atezolizumab plus chemotherapy, followed by open-label atezolizumab in patients with early-stage triple-negative breast cancer. In the inpatient trial, untreated early triple-negative breast cancer with stage 2 and 3, with a primary tumor of more than 2 centimeters, CT2, CT4, CN0, CN3, have been randomized to atezolizumab nab-paclitaxel followed by atezolizumab dose-dense AC versus the same chemotherapy plus the placebo. In the trial, there was a treatment in the preoperative setting and in the postoperative setting. Co-primary endpoint were pathological complete response in intent to treat and PD-L1 positive population. Secondary endpoint were event-free survival, distant-free survival, and overall survival in intent to treat and PD-L1 positive population. So if we look, of course, in the improvement of PCR, the trial already demonstrated an improvement of PCR. Significant PCR benefit from atezolizumab translate in a numerical improvement of event-free survival, not statistically significant, but numerical improvement. Here you can see the data with 168 events in placebo chemotherapy arm versus 165 in atezolizumab plus chemotherapy. That's a ratio of 0.76, 41 event versus 31 event finally. Here it seems the benefit is good in all the subgroup analysis. The exploratory analysis of event-free survival by PCR status demonstrated that PCR is highly prognostic for long-term outcome. So achieving a PCR, it seems to confer a good benefit to the patients. In the non-PCR group, we had finally on atezolizumab 70 events, in the placebo arm 99 events. So in adjuvant systemic therapy, 20% of patients were in the atezolizumab arm, 33% in the placebo arm. In terms of safety, we have no new safety signal. An exploratory analysis has been performed according to ctDNA positivity. And so disease-free survival, overall survival was assessed by PCR and ctDNA at surgery. Here we can see the non-PCR ctDNA negative that have a better outcome. The non-PCR ctDNA positive with a clear poor outcome is 77% versus 23%. PCR ctDNA negative really perform excellently. And looking, of course, in overall survival, non-PCR ctDNA negative have a better outcome with respect to non-PCR ctDNA positive. Looking at overall survival by treatment in the non-PCR patients with ctDNA positive at surgery, the atezolizumab arm performs better. So in non-PCR patients with ctDNA positive, there is a numerical trend that suggests improved overall survival with atezolizumab. So addition of atezolizumab to chemotherapy for early triple-negative breast cancer provides a statistically significant benefit in terms of PCR and numerically improved event-free survival, disease-free survival, and overall survival. Chemotherapy plus atezolizumab clears ctDNA, and presence of ctDNA following surgery is linked to poor disease-free survival and overall survival. What's about the metastatic setting? We had a summary analysis of DESTINY-Breast02, DESTINY-Breast03, and DESTINY-Breast04, including HER2 positive and HER2 low disease. Looking at TDX efficacy in HER2 positive and HER2 low disease, there is a clear improvement in median progression-free survival, 9.9 months in HER2 low, 28.8 months in the DESTINY-3 in the second line, and 17 months in the DESTINY-2 in the third line or beyond. In terms of overall survival, 23 months in HER2 low, 39 months in the DESTINY-Breast02 in later lines, not reached in the DESTINY-Breast03. Comparing key toxicities across all the studies, hematological toxicity is very common. The incidence of alopecia is closer to 38%, fatigue, vomiting, and of course nausea. The median duration of treatment was 8.2 months in the DESTINY-Breast04, 18 months in the DESTINY-Breast03, 11 months in the DESTINY-Breast02. So it's very long, finally, the treatment. ILD was observed overall within a range of 10% to 15%, with no fatal event in the DESTINY-Breast03. Overall survival in the DESTINY-Breast02 was presented during ESMO Breast with an overall survival benefit median of 16.6 months versus 7.3 months in terms of patients without definitive deterioration. It's very interesting during ESMO Breast, some data on rechallenging have been presented. Here we have 5 patients who developed a grade 1 ILD, and then they stopped the treatment and they rechallenged. If you look here in black blue, we have patients previously exposed before ILD. In pink, we have the duration of ILD, and then the rechallenge that is very low. So side effects, of course, are what we know already. And the ILD and pneumonitis, at least for grade 1, should be rechallenged. We have, of course, other data presented during ESMO Breast, the post-CDK4/6 inhibitor setting, in which usually we have really a poor outcome. Following CDK4/6 inhibitors, the median PFS to fulvestrant is close to 2 months, 3.78 months in ESR1 mutant. Only with the BILIV trial, you have 7.3 months. The updated analysis of the Capitello trial has been shown. Men and postmenopausal women who received less than 2 prior lines of therapy and less than 1 line of chemotherapy, with 51% capped for post-CDK4/6 inhibitor setting. Patients have been randomized to capivasertib fulvestrant versus placebo fulvestrant. 80% of patients received a previous therapy for advanced breast cancer, 69% a previous CDK4/6 inhibitor. In the final progression-free survival analysis, there is a median improvement from 3.6 months to 7.2 months, both in the overall population and in the AKT pathway altered population, exactly the same. So capivasertib plus fulvestrant led to significant and clinically meaningful improvement in PFS in patients with HR positive, HER2 negative disease, irrespective of AKT pathway alteration. In the subgroup analysis, the benefit is consistent in all subgroup of patients, including those with previous CDK4/6 inhibitors, chemotherapy, and presence of liver mets. This is the safety profile: diarrhea in 72% of patients, nausea 34%, rash 22%. There is a better toxicity profile compared to PI3 kinase inhibitor with hyperglycemia, but diarrhea and rash sure are significant. Final analysis also of the EMERALD trial. The EMERALD included men and postmenopausal women with advanced metastatic breast cancer, ER positive, HER2 negative, elacestrant 400 milligram once daily versus fulvestrant, aromatase inhibitor, anastrozole, letrozole, and dexamethasone. The primary endpoint was median progression-free survival in intent-to-treat population and VS1 mutant population. And here we have the data. There is an improvement in median PFS, finally, that maintained 20 patients on 20% of patients in 6 months PFS versus 34% of the patients in 6 months PFS. So the median PFS in MAP was better in the elacestrant trial. Don't forget that a longer exposure to a previous CDK4/6 inhibitor can confer a better outcome. So for patients who receive it at least 12 months, there is a median improvement of PFS from 1.9 months to 8.61. So the magnitude of benefit is greater with longer exposure to CDK4/6 inhibitors. Overall, the drug is very well tolerated with a very low discontinuation rate. New data also on camizestrant and fulvestrant. So the camizestrant is the oral SER that was being compared with 2 doses to fulvestrant, and there is an improvement in median PFS from 3.7 months to 7.7 months. The biggest challenge is, of course, this one, when there is a decrease, of course, in the median PFS. The major question for the future will be to develop, of course, biomarkers. We still have only estrogen receptor or ESMO mutation for endocrine sensitive and resistant disease, HER2 positivity for HER2 disease, germinal BRCA mutation for PARP inhibitors, PD-L1 in the metastatic setting for pembrolizumab, and PI3 kinase for alpelisib. The updated analysis, finally, of their HER2-low assessed the benefit of trastuzumab deruxtecan according to ER level. So ER negative 0% or ER low 1 to 10%. And ER low metastatic breast cancer derived a similar benefit from trastuzumab deruxtecan compared to triple negative metastatic breast cancer. And finally, some new data on patritumab deruxtecan, the entire tree in the HR positive disease. There is a clear benefit. And this ICARUS trial have been included patients with HR positive, HER2 negative disease or HER2 low in progression to CDK4/6 inhibitors plus endocrine therapy. The data are very interesting, with 28% partial response, 53% stable disease, and 17% progressive disease. Finally, some updated analysis on the DORA trial, in which it's confirmed that HRD testing in BRCA1 patients can reveal an association between PFS and presence of homologous recombination deficiency, specifically in the maintenance setting. So my conclusion is that trastuzumab deruxtecan is effective independently of ER status. ctDNA, of course, sometimes may predict a lack of therapeutic response. HER3 can be a potential new target for HR positive disease. And we need to better explore the role of homologous recombination deficiency in triple negative disease. And here we have the overall conclusion of the study. The novel ADC are going to be practice changing across many diseases because they are something like smart chemotherapies. And we will see the results of the Destiny Breast 06. Estrogen receptors continue to be a key therapeutic target for HR positive disease. And what we need really is to better identify new markers across the spectrum of disease. Thank you very much indeed, and I will be very happy to take questions.
Professor Miguel Martin Jimenez, from the University General Hospital Gregorio Marañón in Spain, will be presenting ways in which to improve adherence and compliance with oral targeted therapies for HER2 negative hormone receptor positive breast cancer.
Thank you very much. Good evening, dear colleagues. It's my privilege to share with you this symposium. I will devote my talk to try to discuss the ways of improving adherence, compliance with oral targeted therapies for HER2 negative hormone receptor positive breast cancer, particularly abemaciclib. This is my disclosure. Well, high-risk breast cancer of the hormone receptor positive HER2 negative subtype has a dismal prognosis. Here you have a population of patients from Spanish registries, from the HICAM group, fulfilling all the criteria Dr. Curigliano mentioned before for selecting patients for the MonarchE study, either 4 or more axillary lymph nodes or 1 to 3 axillary lymph nodes plus an additional poor prognosis feature. And we have seen at that population, this is 18% of all the patients with this phenotype and operable disease. And you can see in that Kaplan-Meier curve that the 10 years outcome is really bad, with around 40% relapse rate when treated with chemotherapy plus standard endocrine therapy. So there is a clear unmet need for that population. And as Dr. Curigliano mentioned before, the MonarchE study was able to show that adding abemaciclib to endocrine therapy after chemo and surgery plus minus radiation significantly improved invasive disease-free survival after a median follow-up now of 4 years, with an absolute improvement at 4 years of 6%, meaning a 33.6% relative reduction in the risk of invasive relapse by adding abemaciclib to endocrine therapy. So this is a very relevant improvement, but to achieve that, we need to guarantee that patients keep taking abemaciclib along the 2 years of treatment. Because, as you know very well, abemaciclib has side effects as any anti-tumor drug. And here you have in that slide the recording of side effects according to the investigators. This is very important because sometimes it's different. Many times in randomized trials, investigators pay more attention to the experimental arm, to the control arm, and record less events in the control arm that they happen. So anyway, we had 84% rate of diarrhea of all grades, grade 3 smaller than that, 9%. We have other side effects with abemaciclib, 41% fatigue, and some neutropenia, but usually grade 1 or grade 2. These 3 effects, together with some loss of appetite, are the most important side effects according to the investigators. A small proportion of patients also would have venous thrombosis with abemaciclib, particularly when combined with tamoxifen. When combined with aromatase inhibitors, the proportion is much less than that. So the recommendation is try to avoid the combination of abemaciclib and tamoxifen. So, as Professor Curigliano mentioned before, we have had recently in Berlin at ESMO Breast the communication of the PROs, patient-reported outcomes of patients from the MonarchE, with a very good compliance with the planned questionnaires fulfilled at baseline, 3 months, 6 months, 12, 18, 24 months during abemaciclib therapy, and then after that, 1 month, 6 months, 12 months. So the quality of life was very similar overall in patients with and without abemaciclib. So we can conclude from that that abemaciclib does not reduce significantly the quality of life of patients with respect to endocrine therapy alone. Regarding a particular question of the fact VGP5, I am bothered by side effects of therapy. You can see that in the abemaciclib arm, in the first evaluation of 3 months, patients did a little worse than the endocrine therapy alone, but a long time they recover practically basal line status, and this is very similar to endocrine therapy below. Regarding abemaciclib and diarrhea, well, it is clear that proportion of patients up to 80% had diarrhea at the beginning, in the first months, but you can see here that after that, the intensity and the quantity of diarrhea declines over time and disappear versus the basal status after the end of abemaciclib therapy. So to conclude, diarrhea is present in 80% of patients, but most often happens early during the therapy of abemaciclib and is mild in most patients. And a very important thing for an adjuvant treatment, all symptoms due to abemaciclib are reversible upon completion of abemaciclib. So we don't have any sequelae due to abemaciclib when we stop therapy. Well, let's deal a little bit with 4 of the most relevant or frequent side effects of abemaciclib. What about neutropenia? Well, neutropenia induced by CDK4/6 inhibitors is different from chemotherapy-induced neutropenia because CDK4/6 inhibitors produce cell cycle arrest of neutrophil precursors, but not death, while chemotherapy produces DNA damage and apoptosis, and therefore, when CDK4/6 inhibitors, neutropenia is less profound and have a more rapid recovery than with chemotherapy. So we have very few neutropenic fevers with CDK4/6 inhibitors. With abemaciclib, the rate of neutropenia or grades is 44%, but only 1.8% have grade 4 neutropenia. So the recommendation for that side effect is to not modify the dose in case of grade 1 or 2 neutropenia. In case of grade 3, only when complicated with fever or infection, we should reduce a level of dose. When we have grade 4 neutropenia, we should reduce to a lower dose in the next cycle. What about fatigue? Well, fatigue happens in 41% of patients with abemaciclib plus endocrine therapy versus 33% in placebo plus endocrine therapy. So it's a little more frequent than with endocrine therapy, but not much more. And grade 3 happens only in 1.8% of patients. It seems that patients don't perceive the fatigue as a very relevant problem, and anyway, it's not quite different from endocrine therapy alone. Maybe at the beginning, in the first 3-4 months, it's a little worse, but then it's very similar to endocrine therapy alone. Anyway, if we have fatigue, we could recommend exercising. Is the only measure able to reduce the fatigue. And in case of grade 3 or greater fatigue, we can proceed to a dose reduction to abemaciclib. In case of anorexia or weight loss, and this happened, anorexia in 26% of patients with abemaciclib plus endocrine therapy versus 11% in patients with endocrine therapy alone. Although grade 3 is only seen in 1.5% of patients, we can recommend dietary modification because no pharmacological therapies are recommended in that situation, particularly progesterone or something like that. We need to reduce the dose if the symptoms are grade 3 or greater and move ahead with the next lower dose of the drug. Well, finally, diarrhea. Diarrhea happens essentially in the first 3 months of therapy. 82% of patients had one or more episodes of diarrhea, but grade 3 diarrhea is only seen in less than 10% of the patients. And it's very important to understand that diarrhea decline over time, and there is very little diarrhea from month 3 on. What to do with diarrhea, and this is also applicable to other symptoms as well. I think we should share correct information with the patient, emphasize the relevance of therapy adherence, noting that it will improve the outcome of the disease, discuss the management strategies with the patient, for instance, how and when to use loperamide, etc. Provide a prescription for loperamide in order for the patient to have the drug home. Involve further players, including nurses and family members. And finally, assure continuous support via telephone or online applications 24/7 in order to have the patient continuously controlled, particularly in the first 2-3 months that are the most important for that purpose. So if diarrhea persists and is of grade 2, and in spite of stopping the drug and increase loperamide reappears, we should resume the therapy at the next lower dose, and the same if we have grade 3 or 4 diarrhea. We should resume at the next lower dose the drug. This is the levels of dose, the starting dose 150 twice a day, first dose reduction 100 twice a day, second dose reduction 50 milligrams twice a day. And thank you very much for your attention.
Here we listen to the interesting discussion among Chinese and European medical experts. Their discussions focused on a number of topics, such as the early recognition methods for different subtypes, treatment strategies for HR-positive patients who require enhanced adjuvants, the benefits of therapeutics in the Chinese population, and the impact of the clinical strategies used in current investigations.
Good evening, everyone. So, any comments regarding this question? Thank you, Professor Wang, for your kind introduction. Distinguished Professor Shao, distinguished 2 foreign experts. So, for the first question is about the early detection of the high-risk patients of the early breast cancer patients of different subtypes. For the high risk, firstly, we need to refer to the T staging, the tissue grading, as well as the status of the lymph node. All these are the typical pathological features, as well as the Ki-67 levels. Nowadays, as we see the deepened understanding of the oncology, for example, for the triple negative breast cancer, we nowadays have full-down classification, and in the full-down classification, some would be more responsive to immunotherapy, indicating better prognosis. And also for some other patients, they may not draw so many benefits from those treatments. And also for the HR positive patients, what we use most are the gene panels, the 20 gene, 17 gene, or domestic gene panels to help us with the detection of those high-risk population for HER2 positive patients. And in recent years, gene sequencing has not been widely utilized, but for HER2 positive patients, we nowadays have many targeted therapies, which also greatly enhance the prognosis for HER2 positive patients, in addition to clinical features. For example, for the ER negative patients, they may have poorer prognosis. Therefore, for different subtypes, in terms of the high risk detection, in addition to the traditional clinical features and parameters, we also need to refer to the gene sequencing results. Nowadays, it has been widely accepted by the medical oncologists in breast cancer field. Okay, that's all from me. Thank you, Professor Hao, for your kind sharing, touched upon biological and pathological features of the high-risk populations of different subtypes of the breast cancer. Now I will hand over to Professor Dong Chuanhui. Any comments or experiences that you want to share with us? Thank you, Professor Wang, for your kind introduction. For early breast cancer high-risk population, we know that since 2007, we have some Galen consensus regarding the classifications, and also since 2011, we have 4 different subtypings based on the molecular profiling. So in addition to molecular typing for the high-risk early breast cancer patients, we also need to emphasize the TM staging, including status of the lymph node as well as the disease load of the lymph node. That's why in clinical practices, with all these parameters combined for reference, we can define high-risk population. We need to pay attention to lymph node status. In addition to that, we also need to pay attention to histological staging, especially for grade 3 staging, as well as the high Ki67 expressions. So for those population, we need to enhance the treatment and also to have more aggressive follow-ups for different molecular subtyping, for example, for triple negative or triple positive, and also for HR positive patients that are more indolent. We also need to combine the molecular profiling as well as the pathological features to do the comprehensive judgment. Well, as far as I'm concerned, I also echo what MonarchE is studying in terms of the definition of the population that has the high risk regarding the HR positive breast cancer. Thank you, Professor Chuang Gui, for your kind sharing. Now I will also hand over to another professor from China for triple negative patients and HER2 positive patients. How can we identify high-risk population? Because we can also do neoadjuvant as well as the enhanced adjuvant therapy for them. So Professor Tang Peng, regarding the triple negative HER2 positive subtypes, how can we have early detection of the high-risk patients? Thank you for your kind moderation. Actually, clinically speaking, this is also a very hot topic in our practice, because with the successful detection of high-risk patient, we can do targeted therapy, especially for HER2 positive and triple negative subtypes. Compared with HER2 negative HR positive patients, the biggest difference is that for the two molecular subtyping, the risk is higher than the HR positive HER2 negative patients. According to current guidelines, be it domestic or international guidelines, for the 2 subtypes, in terms of the treatment, actually in early stages, we will do enhancement. For the 2 subtypes, we will prefer neoadjuvant treatments. and further enhance the therapies or the detection of the high-risk patients. In addition to the status of the lymph nodes status as well as the pathological staging, we also need to check the neoadjuvant responses, no matter it is the chemo plus targeted therapy or chemo plus the immunotherapy. So when you check the responses.
For the PCR patients, we believe that the relapse risk would be lower than those of the non-PCR patients. But of course, it's also based on the ultimate prognosis data. And for these type of the patients, especially for the refractory patients, either they are HER2 positive or triple negative, we believe that we will have the intensified therapy on them. And in this process, I believe that for this type of the breast cancer patients, it's possible that the neoadjuvant might be a way to screen whether the prognosis would be better, or at least a very important marker, and then to identify whether they are high risk. And also we have the gene testing and more of those, especially for the triple negative breast cancer, and whether you have different stages, whether the familial history is this or that, we do recommend the DRD or the BRCA testing. So that is also included in the guideline. And also for the mutations patients, the risk would be regarded higher, and in general, in these two subtypes, compared with the HR positive and HER2 negative, we can identify the high risk more. Thank you. Thank you very much, Professor Tang. And we have heard that Professor Tampon told us that for the triple negative, and also there is the disease burden and the other indicators. And also while we look at the stage 2 or 3, patients will probably adopt the neoadjuvant more. And the efficacy of the neoadjuvant therapy is a way for us to evaluate whether the patients would have higher risks or not for the relapse and metastasis, at least as a reference. I noticed that the international experts mentioned that after the ctDNA, after the neoadjuvant might have the prognosis. So Professor Curigliano, because I have always admired your vibrant thinking, and not only what our previous 3 colleagues talked about, the high-risk patients identification or detection, then for ctDNA, DNA, or some other aspects, what do you make of that? Of course, we might not have the final conclusion yet, but any observation, experience, or sharing, Professor Julie first. Thank you very much for your guidance, Professor Yongsheng. And for the first question, and we would love to look at the molecular subtyping and to see which are the high-risk patients. The previous 3 have already made it very clear. So I would love to share with you. And I would love to think about how to understand the high risk for the HER2 positive, not only from the pathology, because I think what we need to look for is the mechanism of the resistance. For any kind of subtyping, I think it's the same. We would love to know the mechanism of the resistance, because high-risk patients usually would have relapse, definitely because of different mechanisms. And for the triple-negative breast cancer, as Professor Shao led the trial, which is about the further subtyping of the triple-negative breast cancer. So they are considering the different pathology, because not all of them will be sensitive to the IO or be sensitive to the other types of the chemo. And that means we probably would be more precise and have more subtyping. And for the HER2 positive, I think neoadjuvant is a very good way to screen, especially we can have the intensification, but of course we have TDM1 data. But that's not enough, because the resistance might be relevant to the fact that not really the HER2 enrichment, or they have some other mutations. And then the potential inherent factors might have caused it. And also, as Professor Shen mentioned, the ctDNA, even though in the clinical settings, the ctDNA has not been widely used yet, but we already pay more attention to that. We also hope that with the dynamic monitoring, we'll be able to see whether they will be efficacious to the treatment, or with the dynamic monitor, we can predict whether there will be the relapses, so that we can choose the intensified therapies in order to lower the risk for these groups of populations. And this is what I have agreed with the previous comments. Thank you very much. And thank you, Professor Zhu Li. And then it is really same as Professor Tang Peng. And that's about the triple negative and HER2 positive. And there is the neoadjuvant and how we think about the translational therapy. Then how do we look at the resistance, the mechanism of the resistance as well? I believe that for the early breast cancer curing, that's going to be very important in the neoadjuvant setting. Then we can look at the different targets of the resistance and then try to adopt the neoadjuvants. Because we know that for the neoadjuvant model has changed because the traditional neoadjuvant have got the different randomization groups, and after the neoadjuvant and then surgery, then we see whether they have got the PCR or they are residual tumor burden for the further therapies. But right now, that's really about adaptive design for the neoadjuvant, just as we have heard from Professor Zhu Li. So that means after the duration for about 2 to 3 cycles and of the neoadjuvant, whether it's for the chemo IO for the triple negative, if they are not sensitive, then we can explore the mechanism of the resistance. And I believe that we can also use that neoadjuvant, and we believe that we can avoid the blind therapies for the early breast cancer. Thank you, all the 4 domestic experts for the sharing. And next, I'm going to ask our experts from ESMO.
Now I will ask for ESMO experts. This topic is how to identify high-risk early breast cancer in different subtypes. I want to Professor Curigliano first to share your experience. Okay.
Oh, yes, of course. Yes, of course. Regarding risk stratification, the most important is related to HR positive, HER2 negative disease. Usually the assessment of the risk is a multidimensional evaluation, including the stage, so tumor dimension, nodal involvement, the biology, grade and Ki67, and finally the genomic assays, because we know perfectly that some tumors that may appear intermediate risk according to clinical pathological features may become high risk on a genomic assay. So I believe risk assessment in this disease it's really essential to be evaluated because it may give us the opportunity to escalate treatment. One example is the use of Abema plus endocrine therapy. Another example is the extended Adjuvant endocrine therapy. I believe personally that in the future, to better assess the risk, we will use also artificial intelligence. Because believe to me, the opportunities of AI are really huge. And you know that actually there are also some tools in AI that may translate the morphology on the slide on the genomic score. So there is a strict concordance between what is assessed by digital pathology and potentially the high risk according to genomic assay. For HER2 positive disease, of course, the risk is per se related to the residual disease after neoadjuvant treatment. Is still a medical need over there for the rate of relapse and also for the brain mets. And finally, for the triple negative disease, for sure residual disease, and now also ctDNA is really an essential way to assess the risk of relapse.
Thank you, Professor Curigliano, for your experience. And now I will ask Professor Martin to share your experience.
Well, I fully agree with Professor Curigliano's comments. He described very well the way we should determine the risk of relapse of early breast cancer patients. It is very different according to the subtype. And I think that once we have established the risk, we should, by the means he mentioned before, including TNM staging, including biological factors, ER expression, HER2 expression, K67, genomic platforms were indicated. We should classify the patient at low, intermediate, or high risk and administer the appropriate therapy accordingly. My talk was devoted to a particular topic, but important enough, I think. We should use the best therapies available, but we should do things in a way that we can make sure that the patients are taking the pills, in the case of abemaciclib, in the most appropriate way, because we could have the better therapy, the best therapy available. If the patient don't take the pills, it doesn't work, of course. So for me, the key point in guaranteeing adherence to therapy is talking to the patient, speaking with the patient, maybe half an hour or more, answering all her questions, providing her with all the means to get in touch with us if she has problems, particularly in the first months, because in the first 2-3 months is where most side effects could lead to non-adherence to therapy in oral drugs, particularly in abemaciclib, but also with other oral drugs. And with the help of other players, maybe family members, maybe nurses and other staff from the hospital, using, if available, applications, mobile applications, we should make sure that the patient is always able to ask questions in case of doubt, and we could provide her with the appropriate solution for their problems. With that approach, I can tell you that I haven't seen a single patient in therapy with abemaciclib stopping therapy due to side effects.
Thank you, Professor Martin. Professor Martin is especially emphasizes the importance of patient preference and discuss with the patient and even their families for the treatment choice. Now we will move to the next question.
The second question is that what are the populations in the early breast cancer with HR positive need the intensified adjuvant therapy, and what are the strategies of intensified adjuvant therapies? And for experts here are also the ones with a lot of these thoughts. And of course, you can talk with our international experts if you have questions so that we can be interactive too. So for this question, that means it's a follow-up question of the previous question, only we're focusing more on the HR positive, and also then Professor Song, would you share with us about your experiences? Professor Song, you're not on mute. All right, sorry, I didn't unmute myself. And for the HR positive early breast cancer, the intensified adjuvant therapies, I believe that there are many therapies that according to the pathology and analysis and the gene panel, we would be able to identify those potentially high-risk population. We noticed that there are a lot of the intensified adjuvant therapies because for the HR positive, the most important thing is that in the adjuvant, we need the ET. And in the intensified ET, there are a lot of the regimen. For example, especially we pay attention to the OFS and especially how to combine that with the AI. And there is a lot of the lymph node burden and also BCI indicator to see who would be those for the extended duration of the intensified adjuvant therapy after 5 years or even in the second 5 year. These are what we use a lot. And
also based on MonarchE study right now, for the patients that are indicated for MonarchE criteria. And for those high-risk population, we need to utilize abemaciclib to do the consolidative treatment. Nowadays, we have more and more persuasive data to support that, so we're more than willing to add those drugs. And also for HR-positive early breast cancer patients, after the enhanced adjuvant therapy, we may also need other on-study drugs to treat them, but they are not accessible. Okay, that's all from me. Thank you very much. Thank you. Thank you, Professor Chuan Gui. I understand that based on the specific patients as well as the risk for relapse and also tumor burden, we can do the related enhanced treatment such as the ovarian inhibition and also to add the AI and also to have the prolongation of the adjuvant therapy. Nowadays, based on the MonarchE study, we can introduce the CDK4/6 inhibitors such as the abemaciclib to do the further enhancement. In terms of the strategies, we will choose high-risk patients, just like Professor Julie and also Professor Tang Hong underscored. For high-risk population, sometimes they may not be sensitive to the enhanced endocrine treatment, because if we utilize the AI, sometimes they can also have good control for MonarchE. Of course, it has the clinical meaningful and statistical significant difference. However, for the beneficiaries, difference is only 6 to 10%. And also only 6 to 10% can have the extra benefits. So how can we do precise enhanced endocrine treatment? I will give this question to Professor Tang Hong, please. Thank you, Professor Wang, for your kind introduction and the question. Currently speaking, I don't think we have these precise tools to help with the diagnosis. Currently speaking, we're also working very hard to identify the markers or indicators. For example, ESR1 mutations, one of them. And also in this regard, for AI itself, they are resistant. If you add the CDK4/6 inhibitors, the response will not be good. But for those patients, right now for early breast cancer patients, we will not utilize the fulvestrant at the front line. Right now, we don't have the evidence to support that, because in advanced breast cancer, we do have the clinical trial with the related data to verify this practice. That's why it may also takes time for us to come up with some persuasive data to support related treatment practice. And also in our center, we're also doing related trials during the NGS for the patients to identify whether they have the related gene mutations and also to guide our treatment. However, few patients can afford this test, and we sincerely hope that in the future we can have the large-scale clinical trials to identify easy and quick and cheap assays to help us screen out those patients that can draw benefits from the individual treatment protocols. I understand this is a long journey. It still takes time for us to achieve our goal. Thank you, Professor Tang Hong, for your kind sharing. And I think you also touched upon the importance and the necessity of the precise and individualized medicine. And we hope that for MonarchE or Natalie studies, they can have great success. And also in terms of the translational studies, they are also able to give us some meaningful biomarkers to guide our treatment. Well, for those studies, right now, they cannot give us a definite biomarker to guide the enhanced adjuvant treatment. Before we, have that biomarker, is there any other methods for us to do the treatment? Because in this year's St. Gallen meeting, they also had done a voting regarding that for some patients, we can have the chemo-free, valuable information, and also they can guide our treatments. So Professor Julie, this question is for you. Maybe through new adjuvant endocrine therapy, for example, the patients have reduced the Ki-67, and also the treatment index is decreased. Based on that, maybe we can do escalation, de-escalation of the treatment. Professor Julie, please. Thank you for your kind question. For neoadjuvant endocrine treatment, I also pay a lot of attention to that. Well, currently speaking, there are many studies going on that are still in the trial status, and according to ASCO guideline, they only recommend that in elderly patients that cannot tolerate surgery nor chemo, we can do neoadjuvant. So that's a recommendation, but as an explorative study, we will not stop here, especially for surgeons. Personally speaking, actually, regarding the question and a point made by Professor Wang, I echo with you, because in the international community, we have very large scale study comparing the Ki-67 levels 2 weeks after surgery. If the Ki-67 is significantly decreased, we can have the chemo-free regimen, and they can also have better prognosis. And also in Germany, Professor Habeck is also doing the chemo de-escalation or chemo-free treatments for luminal type patients. So after 1 or 2 months treatments, if the Ki-67 is decreased, they will no longer give them chemo anymore. So I think for those exploratory studies, they are of great value, because for luminal type patients, we would also have discussions whether the patients need enhanced treatment, whether the patient need PARP inhibitor, whether the patient need the escalation of the chemo in terms of the de-escalation studies. When you screen out those patients who do not need chemo, well, just like Professor Mang mentioned, who are the patients that don't need the enhanced adjuvant chemo? Right now, we don't have a specific answer to it, but for neoadjuvant endocrine therapy, we're also doing some exploratory study, for example, to have HDAC inhibitor in combination with Western to treat some patients in a neoadjuvant setting, but it's still in the study. Right now, we cannot copy it to our clinical practice. Thank you, Professor Julie. Can I have a question? Because I noticed that we have 2 ESMO experts.
Okay, can I ask a question for Professor Curigliano? And in your presentation, I noticed that in patient 031 study, you show that no matter the patient receive immunotherapy or not, if they achieve PCR, the survival is better than non-PCR group. So do you think it is any biomarker to help us to distinguish which patient will not receive or cannot benefit from immunotherapy, because maybe their chemo for them is enough? Thank you.
Well, this is a very good question, I believe. Unfortunately, in the neoadjuvant setting, neither the KEYNOTE-522 or the patient 031 really demonstrated a predictive biomarker, because the rate of PCR is independent of PD-L1 expression. In some subgroup analysis of the KEYNOTE using pembrolizumab, it seems that higher is the CPS score, higher the rate of PCR. This is an unplanned analysis just presented in a meeting, never published, but Peter Schmidt performed this analysis, and increasing the CPS score 10%, 20%, 50%, higher it is, higher is the rate of PCR. So, of course, we cannot use PD-L1 determination in the neoadjuvant setting because the label is not associated to a test, but I personally believe that higher immunogenic is the tumor, more potential is the benefit of immunocheckpoint inhibitors. And so this is, of course, something that we should assess maybe for the future.
Okay, thank you for the opinion. And can I ask another question for Professor Martin? And because we know that in MonarchE study, we don't have the information about the BRCA mutation status. So if the patient, you think it's high risk luminal patient, and if she had a BRCA mutation, which kind of enhancement for the adjuvant therapy you will recommend? PARP inhibitor or CDK4/6 inhibitor, or the combination of both? Thank you.
Well, this is a very good question. All of us are doing to ourselves every day when we have a patient with BRCA mutation and a luminal tumor. So based on we know today, I think that the strength of evidence favors the use of olaparib in that particular case, because the Olympia adjuvant trial showed not only an improvement in invasive disease-free survival, but also in overall survival. And with abemaciclib, we have not shown yet an improvement in overall survival. So at that point in time, I would recommend to use olaparib in that particular patient. I don't think we could combine both drugs due to toxicity. And the use in sequence is also problematic because you have to give 3 years of therapy with some side effects. So today I will recommend olaparib in case of BRCA2 mutation.
Okay, thank you very much.
I also want to ask to ESMO experts that we all know the importance of intensive adjuvant therapy for high-risk patients. Can you share your experience on the direction of research, how we can give individual intensive therapy, for example, for HER2-positive high-risk early breast cancer?
Excuse me, I couldn't understand very well your question.
Okay, so I'm going to repeat the question in Chinese. So we all know that for high-risk early breast cancer patients, the enhanced treatment is very important for HR-positive patients. But for all the patients, if we all do enhancement, that will be over-treatment. So how can we have the individualized enhanced adjuvant treatment strategies and also choose, for different patients? Right now, we don't have adequate evidence to support individualized approach. So do you have any guidance or suggestions as how to do individualized enhanced treatment in the adjuvant setting? Thank you.
Well, I think that tools we have today to individualize therapies has been discussed before by Professor Curigliano. I think that we should look at a number of factors, including the stage of the disease, the TNM or UECC classification. Still is very important. The involvement of axillary lymph nodes is still the most important prognostic factor. And we should first establish the prognosis of the patient. And after knowing the prognosis and having the patient classified as low risk, intermediate risk, or a high risk, we should select the most appropriate therapy for the patient. We should be aware that prognosis and prediction is not the same. But there is some link between them. And what we know so far is the worst the prognosis of patients with hormone receptor positive, HER2 negative disease, the more effective is chemotherapy. So my approach to that question is to establish first the prognosis using TNM and biological factors, including K67, grade, and other factors. Maybe genomic platforms, if available. And then once established the prognosis, discuss with the patient what we could gain by adding, for instance, chemotherapy to endocrine therapy or abemaciclib to chemotherapy plus endocrine therapy, and select the most appropriate therapy according to both the doctor and the patient.
Professor Curigliano, can you share your experience for the research direction for the individual intensive therapy for HER2 HR positive early breast cancer?
So the research priorities, I believe, are actually the ones that may permit us to better stratify the risk. Because you would agree that some patients are clinical high risk, but maybe genomic low risk. An example is the lobular cancers. No, in lobular cancers, if you perform a genomic assay, in the majority of the cases, you will find a low risk on genomic assays. So for the future, I believe a multidimensional integration of clinical pathological features, genomic features, potentially immunofeatures, and also the use of traditional pathology may help us to better stratify the risk. This will be essential because in a few weeks from now, 1 week, we will have also the data of ribociclib in the adjuvant setting, in which the drug seems to work also in intermediate risk. So we need, of course, to better assess risk in order to maximize and escalate treatment where is needed, and de-escalate where we don't need to do more.
Okay, thank you, Professor Curigliano.
And last, for this question, I would love to ask Professor Hao Xiaopeng for the comments after the very good interactions. And Professor Hao Xiaopeng is also with a group of the St. Gallen. So the second topic, why don't you share your summary? Thank you, Professor Wang. I'm not in a position for the summary, but I would love to share with you my comment because Professor Yongsheng and the other experts mentioned some shared view. Because at the clinical practice, we are looking at the markers to see whether they are high risk and then decide on the intensive adjuvant therapy. And also we can use the genomic marker to identify the high risk for the intensive therapy. And also for the neoadjuvant, as you just mentioned earlier, that means in vitro, we have got the test in the patients, and then we have different stratifications of the risks. And those with the PCR would have good prognosis without any doubt. And those without the PCR, they need the intensified adjuvant therapy, except for the MonarchE, but also we have Olympiad E. And we also included HER2 negative patients, and that includes the HR positive patients as well, just because they're HR positive, because we want to include them so that we can identify more about the ET to extend that for capecitabine and olaparib when the AEs would be more serious. We do not pay enough attention, relatively speaking. So coming back to this platform, we try to screen those patients who would be more sensitive to the neoadjuvant and ET, and also the ET adjuvant therapy later. So in the neoadjuvant setting, as you just mentioned earlier, whether it's the 2 weeks, the re-puncture ones and the de-escalation, but also in the clinical setting, when there are those cells, a proportion that have been arrested, and then we have surgery, and then we have the score, they're also efficacious. That means if the treatment is good or efficacious and P1, P is a 0 or 1, that's similar to RCB, and then they can be exempt from the chemo. And then they would be efficacious to stay on the ET later. And for the early breast cancer patients, how do we deal with the sequencing so that we can exempt them from the chemo? so that they can get into their intensified therapy that's more efficacious for them is more important. Thank you very much, Professor Xiaopeng, for your summary or overview. Next, we will get to the third topic. In the MonarchE trial, are the benefits for the Chinese population consistent with the overseas population? Professor Tampeng, would you love to share with us your views first? Thank you very much, Professor Wang. I'm not in a position to share my experiences, but definitely I would love to share with you about how to look at the data. And we'll look at the MonarchE. I believe that we have included some of the Chinese patients. Here we can also see that there is the overall benefits and they are consistent with the ITT population. We also noticed that DFS have got that and PFS have got that benefit, but OS is not mature yet. It takes longer. So that means for this type of agent, whether it is the one that will cover different ethnicities or nations, and in China, we didn't see more AEs either. And in the clinical practice, my personal observation is that the AEs might not have been higher than that in the trial, like diarrhea. So relatively speaking, probably even fewer patients who suffer from the diarrhea than the trial. Probably it's related to how Chinese people are working hard, I'm not sure. But then the AEs or the other way around, the tolerability would help the patients to stay on the agent so that they can benefit more. Thank you. Thank you very much, Professor Tampeng. And I believe that Professor Tampeng has made a good comment on the MonarchE for the Chinese population and on the overseas population, they are consistent. And that includes the AE and also the efficacy. Professor Zhu Li, what's your make on that? Would you please share with us your personal observation? Sure. So Professor Tampeng has made a very good comment. I completely agree. I also want to say that in the updated data, we noticed that after the analysis of MonarchE for multiple times, when we look at the persistent benefits, I have some of my own observations. Because for luminal breast cancer, we know that there might be two peaks of the relapses. So we not only pay attention to the early relapse, we also pay attention to the relapses from 5 to 10 years or even longer. And that's a later relapse. So for luminal, if you only have 2 to 3 years of the follow-up, almost all of the experts would believe it's not enough. That's why the TechSoft trial have got the data. And at the very beginning of the data, we believed that we need longer follow-up. And now we have got 12 years data of the TechSoft. So we believe that the OS and this kind of intensification will bring the benefit to the young population. We also believe CDK4/6 inhibitors would encounter the same situation for the adjuvant intensification, because after the follow-ups for many times, we noticed the persistent benefits and also greater depth of the response, and the curves are spreading or separating more. Even though OS did not see the benefit, but for luminal BCE and the large assistive trial, it's really hard to see the benefit of OS, because after relapse, we have a lot of the options for the salvage. So the OS might not be greatly boosted for the benefits. And also the ATEC as a larger trial, even though the DFS, IDFS have got the benefit, but OS was still not so much, or it's really hard to see the benefit. Therefore, in the luminal and in the assisted trials, that's very common. And that's why in the early relapse risk, if we can reduce that risk, that's more important. And I also agree that with the high-risk patients, especially for those with 4 lymph nodes with a metastasis, I would use abemaciclib. And the other thing is about the neoadjuvant screening for the Penelope B. And that means if they're not good with the neoadjuvant, they will use the palbociclib for the intensification. And I think that for the luminal B, if we use neoadjuvant for screening, I don't agree so much because we used the chemo for the luminal and they are not sensitive to the chemo. It doesn't necessarily mean that the prognosis would be poor because we can use the ET to make it up to lower the risk. So personally, I believe that Penelope B's design of the trial is not something I agree with because I agree with more on MonarchE even until now. Thank you. I agree with what Professor Julie mentioned. And that means with the neoadjuvant chemo, will be able to screen some patients, and therefore the intensified adjuvant, but they're not the good approach. For example, we can have the neoadjuvant and the ET, and the Ki-67 did not decrease. Then we use the AI. And the other thing is that in the AI backup, we can add the CDK4/6 inhibitors, and that would get us a better positive result easily. Okay, so in the interest of time, let's get to the next question, which is the final question. And number 4. May we pull out the number 4? All right, it's up. So our experts have already emphasized that while we're making our decisions of the therapies, we also need to follow the patient's preferences, and also that matters. So in the ESMO's report, there is also the PRO results from MonarchE. So I would love to invite Professor Hao Xiaopeng to share with us about the first question. What are the implications on the clinical strategies from the latest PRO in the MonarchE? Professor Hao. Thank you very much for your question, Professor Wang. It is true that while we're improving the survival, we are also mentioning more about an improvement of the quality of life, and more research or trials at the final stage would look at the AEs and also the quality of life and get the scores into the trial results, especially in the ET treatment. We know that the impact on the quality of life is more mentioned, and the ET is different from targeted therapy or chemo because it's related for the long duration. It starts from 5 years to 10 or even 15 years. CDK4/6 inhibitors would be on the duration of 2 years or so, even longer. And with such a long duration for this kind of therapy, when we look at the impact on their quality of life and the adherence or the compliance, it's very important. And in the earlier days of the management of the compliance, we noticed that overseas, when you look at the EurAsia, it's the tamoxifen or the 3C or the AI, then about over 90% of the patients would just have some missed dose within a year, and then 60% would fail to be compliant in 1 to 2 years, or discontinuation, or simply missed dose a lot. And for Chinese patients, we noticed that some of the small sample size were looking at the compliance for the ET therapy. And we noticed that for the Chinese patients, probably the compliance is better compared with the overseas patients. It's probably because of the fear of the Chinese patients more, and not so much a high quality of life, or sometimes they pay more attention to the agents that they have already paid. So for the MonarchE, we noticed that abemaciclib led to the AEs, but in them, mainly there are diarrhea and the neutropenia. So especially for the AEs that they exist in the early treatment, especially first 1 to 2 months, and most of the discontinuation occurred only in the first 1 to 2 months. But with the proactive prophylaxis and management, most of the patients will be able to insist on through the first 1 to 2 months, and then we can see the discontinuation rate would drop as the time goes by. So that means for the 1 to 2 year duration of the ET, we need to pay attention to the AE and to this quality of life, so that we will be able to get the prevention in place in the early days to improve the quality of life. Professor Wang? Sure, thank you very much, Professor Xiaopeng. In the interest of time, so number 3, number 4, we would love to ask Professor Tang Peng for the summary. Thank you.
Professor Chang Gui. Well, for the third and the fourth questions, currently speaking, based on MonarchE, especially for the updates from this year's ESMO, so we've seen the subgroup analysis of the Chinese population of the MonarchE. All these data indicated that based on MonarchE study results, actually based on the definition of the high-risk population, we can use the MonarchE protocol to treat those patients. Therefore, for the Chinese patients, we can actually utilize those data to guide our treatment. Clinically speaking, we also have very good experience, especially for the abaciclib-induced diarrhea. I understand in many other drugs utilizations, we also have experience of managing the diarrhea, so it will not be the biggest barrier. And also for patients that are used to the treatments and as they have overcome the diarrhea in early stages of the treatment, they are able to have persistent and high compliance utilization. So according to PRO from the MonarchE, we're seeing very limited reports of the diarrhea. So in the ESMO report, we also underscores the importance of the enhanced treatments for the high-risk early-stage population. Okay, thank you.
Have you posted your work in the comment box below? We welcome your own cases, best practices, and research data. By taking advantage of P2P's viewership pool of tens of thousands of professionals, you can really make your work known to global peers. Don't miss out on this chance to expand your network in no time.